everyone. Today we're taking a deep dive into systemic lupus erythematosus, or SLE. I'll explain what it is in one line, show you the stepwise biology behind it, walk through typical clinical features, list the most useful investigations, discuss complications, and finish with a clinical vignette that ties everything together, and importantly, why each step changes what we do for patients. SLE is a systemic autoimmune disease driven by loss of immune tolerance, production of pathogenic autoantibodies, and immune complex deposition that causes inflammation in multiple organs. Step 1, genetic predisposition plus triggers. Some people inherit genes that make their immune system more likely to react to self. Common examples include certain HLA types. But genes alone are rarely enough. Environmental triggers, such as ultraviolet light, viral infections like EBV, or some drugs can set the process in motion. Knowing triggers helps with prevention. For instance, strict sun protection often reduces flares. Step 2, loss of B and T cell tolerance leading to autoantibodies. Normally, the immune system deletes or controls self-reactive lymphocytes. In SLE, this tolerance breaks down. B cells start producing anti-nuclear antibodies, ANA, and more specific antibodies like anti-double-stranded DNA and anti-SM. T cells that should regulate immune responses are also dysfunctional. These autoantibodies are not just markers. Some, like anti-dsDNA, form immune complexes and drive tissue injury. They're also useful in diagnosis and tracking disease activity. Step 3, immune complex deposition leading to complement activation and inflammation. Autoantibodies bind antigens and form circulating immune complexes. These deposit in tissues, classically the kidney glomerulus, skin, and blood vessel walls, and activate complement. Complement proteins then recruit inflammatory cells that damage the tissue. Low complement levels, C3 and C4, often reflect active disease. This immune complex mechanism explains why SLE can affect almost every organ, and why therapies that reduce antibody production or inflammation, such as steroids, immunosuppressants, and B-cell therapies, work. SLE is protein, meaning it shows up in many ways. Let's group the features by system and understand the reason behind them. Constitutional symptoms include fatigue, low-grade fever, and weight loss. Chronic systemic inflammation and cytokines drive these nonspecific symptoms. Fatigue is often the most disabling complaint. Skin and mucosa involvement includes photosensitivity, the classic malar butterfly rash across the cheeks and nose, discoid lesions, and painless oral ulcers. Immune complex deposition and local inflammation in sun-exposed skin cause rashes. Photosensitivity is a common trigger for cutaneous flares. Joint involvement shows as non-erosive inflammatory arthritis, painful, swollen joints, but typically without the erosive damage seen in rheumatoid arthritis. Synovial inflammation from immune activation causes pain and stiffness. Preservation of joint architecture differentiates SLE from RA on X-ray. Kidney involvement presents with proteinuria, hematuria, or rising creatinine, lupus nephritis. Immune complexes deposit in glomeruli. Histologic class on renal biopsy directs intensity of therapy. Renal involvement is a major determinant of prognosis. Serosal inflammation includes pleuritis or pericarditis, sharp pleuritic chest pain, or pericardial rub. Serosal surfaces are frequent targets of immune complex inflammation. Neuropsychiatric features include seizures, psychosis, and cognitive dysfunction. These are grouped as neuropsychiatric lupus and result from direct immune injury, vascular events, or autoantibodies affecting the CNS. Hematologic abnormalities include autoimmune hemolytic anemia, leukopenia, and thrombocytopenia. Autoantibodies can target blood cells or bone marrow, causing cytopenias that may require specific treatment. Thrombosis with antiphospholipid antibodies leads to recurrent clots or pregnancy loss when anticardiolipin or lupus anticoagulant antibodies coexist. These antibodies create a prothrombotic state, changing management to include long-term anticoagulation in many patients. Now the key investigations, what to order and why. ANA is the starting point. ANA is very sensitive for SLE. Most patients are ANA positive. A negative ANA makes SLE unlikely. It's a screening tool, inexpensive and widely available. If ANA is positive, look for specific antibodies. Anti-dsDNA is relatively specific for SLE and often correlates with renal activity. Anti-SM is highly specific but less sensitive. Anti-Rho or SSA and anti-Ella or SSB are associated with subacute cutaneous lupus, neonatal lupus risk, and certain photosensitivity patterns. These tests help confirm the diagnosis and give clues about likely organ involvement and prognosis. Complement levels. C3 and C4 are checked next. Low levels often indicate active immune complex disease and a risk of organ flare, particularly nephritis. Complements are consumed in immune complex formation. Low values are actionable markers. Basic labs and organ screens include a complete blood count for cytopenias, ESR and CRP for inflammation, LFTs, renal function, urinalysis, and urine protein quantification. Urinalysis should be done at every visit if SLE is active, as it detects early kidney involvement. Renal biopsy is indicated when there is significant proteinuria or declining renal function. It categorizes lupus nephritis into classes 1 to 6 and directly informs treatment choices. For example, aggressive induction therapy for class 3 or 4. Management of nephritis is organ-specific and biopsy-guided. Outcomes improve with appropriate, timely therapy. Complications to watch for include lupus nephritis, leading to chronic kidney disease, accelerated atherosclerosis and cardiovascular disease, infections from immunosuppression, and obstetric complications with antiphospholipid antibodies, such as recurrent miscarriage and preeclampsia. These complications determine long-term outcomes. Early prevention, monitoring, and specialist care improve survival and quality of life. Now let's look at an example. A 22-year-old woman presents with a photosensitive rash and joint pains. Her labs show low C3 and C4, positive anti-dsDNA, and increasing protein on urinalysis. Her creatinine is rising slowly. A renal biopsy demonstrates class 4 lupus nephritis. Class 4 indicates diffuse proliferative nephritis, a severe organ-threatening form. Because immune complexes damage the kidneys, she requires prompt aggressive induction therapy, usually high-dose corticosteroids, and a cytotoxic agent or mycophenolate to stop inflammation and prevent permanent scarring. We also start hydroxychloroquine for general lupus control and institute close infection surveillance given the heavy immunosuppression. Over months, we track anti-dsDNA and complements. If anti-dsDNA falls and complements normalize, it generally correlates with treatment response. Monitoring involves regular clinical review, urinalysis at each visit, periodic anti-dsDNA and complement levels, and organ-specific tests as indicated, such as echocardiogram if pericarditis or brain MRI for neurological symptoms. Disease activity scores like SLE can help quantify changes over time. Prognosis. With modern therapy, many patients do well, but organ damage accumulates with uncontrolled activity and steroid toxicity. Early aggressive treatment for organ-threatening disease, plus steroid-sparing strategies, improves long-term outcomes. Patient education includes sun protection, infection awareness, contraception and pregnancy planning, vaccine optimization before heavy immunosuppression, and awareness of red flags such as fever, new shortness of breath, or hematuria. Empowerment and prevention reduce flares, prevent irreversible damage, and improve quality of life. To sum up, SLE is a complex, multi-system disease driven by autoantibodies and immune complexes. We diagnose it with a combination of clinical features and serology, ANA screening, then specific antibodies, complements, and organ testing. Renal involvement is a major determinant of treatment intensity and outcome, so urine monitoring and timely renal biopsy can be life-changing. Finally, coordinated care, early appropriate immunosuppression, infection prevention, cardiovascular risk control, and patient education is the key to living well with lupus. Thank you. That was an overview of SLE with stepwise pathogenesis, clinical features, investigations, a case vignette, and practical points for monitoring and why each step matters.